Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Nur Azmi bin Muhammad Hisam. I'm presenting challenges in trauma resuscitation for MEDEX 2021. There are several challenges pertaining to trauma resuscitation. My outline is coordination, logistic, clinical, and infectious control. As for coordination, usually if a trauma patient presented to hospital, they will presented with multiple problem. This involve multiple discipline involvement. Currently in our situation in Malaysia, there are 141 hospital under Ministry of Health, but only small amount of them are regarded as trauma center. The function of trauma team basically just to expedite the management of trauma patient and improve the mortality rate. Petri D et al. In 1996 done a research patient with ISS more than 12 had a significant better outcome when a trauma team was activated. Second problem is a logistic problem. A lot of hospital, district hospital, especially in Malaysia, are far away from the tertiary hospital, especially the trauma center. Uh, in 2017, Joshua B. Brown done a research, noted there is a median fatal rate of 0.187% per 100 million VMT. They noted also the increment of fatality rate 0.141% for every 10 miles farther from the nearest trauma center. That's mean the mortality and fatality rates is increased every 10 miles farther from the nearest trauma center. Thus, the importance of clustering trauma services. In 2014, Malaysia Ministry of Health already initiated the cluster hospital program just to share the resources and expertise between tertiary hospital and nearby district hospital. So let's say if a trauma patient presented to Hospital Mersing, which is 2 hours away from my hospital, Hospital Sultan Ismail, this patient will be initially stabilized by the EMTS Hospital Mersing prior to transfer to tertiary hospital, which is Hospital Sultan Ismail. I think this will increase the survival rate post-trauma. The third issue is a clinical issue, which is a traumatic cardiac arrest. In 2010 in London, they noted the survival rate of traumatic cardiac arrest is 0%. Locke and his colleague in 2013 developed an algorithm for traumatic cardiac arrest. Surprisingly, it increased the survivability up to 7.5%. Later, Sharon and his colleague at Sydney in 2013 makes a detailed approach to traumatic cardiac arrest. However, there are no survival data from this algorithm. In 2018, ATLS later come out with its own traumatic cardiac arrest algorithm, and I believe this is adapted from previous both algorithm from Sydney and also London. It is noted that penetrating thoracic injury survival rates are around 9 to 12%. However, also has been reported as high as 38% post-emergency thoracotomy. This highlight the importance of trauma team in every trauma center. Survival for blunt trauma is, however, only around 1 to 2%. Last but not least, COVID-19 is everywhere. It is a matter of infectious control because patient of COVID-19 may have symptoms or asymptomatic upon presentation to us. So let's say if they presented to us unconscious and intubation must be done, this procedure is an aerosol generating procedure. Bellingham et al. In 2020 noted in British Journal of Anesthesia, procedures such as intubation must be done in negative pressure ventilated room, plus the medical personnel attending the airway should be dressed in airborne precaution personal protective equipment. Thus, my presentation comes to an end. Thank you for listening. Thank you all.